moving towards our very last session before the lunch break. GLP-1 are a class of drugs which are used widely to treat type 2 diabetes. To focus on this topic, initiate at onset early intervention for effective control with oral semaglutide. We have our next speaker with us, Dr. Hridish Narayan Chakravarti, consultant endocrinologist attached to Narayana Hospital, Howrah, and Manipal Hospital too. He is the former associate professor of Department of Medicine, Kolkata National Medical College. And to chair this particular session, we have two senior most consultant with us, Dr. Jyoti Dev Mukherjee, senior consultant endocrinologist, former HOD, Department of Medicine, Professor, SSKM Hospital, Kolkata, and Dr. Dasharathi Shorka, senior consultant endocrinologist at Calcutta Medical Center, GD Diabetes Hospital, and former faculty of SSKM Hospital, Kolkata. I will like to request both the chairperson to please be seated and introduce our speaker.
Good afternoon, everybody. We are running late. So just a few words. You know, for last few years, the diabetes management has been totally changed. Initially, it was stepwise management, lifestyle modification, metformin, sulfonylurea, and then others. But now the different guidelines also they advocate that divide the diabetes patient into two groups. One, presenting with complications, or presenting without complications. If presenting with complications like cardiovascular complication, renal complications, hepatic complications, then start the newer drugs straight away, like DPP-4 inhibitor, like SGLT2 inhibitor, GLP-1 receptor agonist, and insulin as and when necessary. Now today, Dr. Hridish Narayan Chakravarti will cover the newer drugs, GLP-1 receptor and its efficacy. Semaglutide, it has in oral form and injectable form. He will focus on the role of semaglutide on the diabetes management. Read this, please.
Good afternoon, everyone. So what better time can I have than to talk on semaglutide when it is pre-lunch session? So I was just thinking of taking a vote whether you would be wanting to have it. So thank you, HDS, for giving a platform to talk on this particular topic, and thanks chairpersons for kindly introducing me. So in the next, how much time do you have? Do you have the timer?
20 minutes.
Okay. So my slides are not coming here. Yeah, so the topic will be initiate at onset early intervention for effective control with oral semaglutide. Now, GLP science has undergone a sea change and similarly has the treatment of type 2 diabetes. So it's understood there is a clear unmet need to avoid complications with early type 2 diabetes management because it's a progressive disease. So with time, maybe the pancreas is going to falter more, the insulin resistance is going to increase, and we would be just adding up drug one after another to ultimately find a good glycemic control and prevent complications in the later part of diabetes. So clinical burden is a huge one. What we need to understand that the comorbidities are also crawling and cropping up as the patient progresses in diabetes trajectory. So it's just like a banyan tree. The stem is the diabetes and you have the branches and sub-branches which ultimately make you so heavy that it hangs down. So sugar plus target organ damage is the total cost that the patient bears throughout his life. So we should not be always considering that when you are giving a molecule that will be initially very costly. The thing to be understood is that what is the total trajectory of the patient right from the starting of diagnosis till he ends his part in this part of the planet. How is the cost going on throughout? Whether you can prevent some complications in the path of that trajectory, and that can bring down the cost as well. So this part has to be remembered. Economic burden of early onset diabetes. This is also very important. So when we were young, when we were kids, we learned that the diabetes diagnosis occurred around 50, middle age. But now things have progressed or preponed to such an extent that in late 20s also we are getting early type 2 diabetes. So the problem is the patient leads a huge part of the life in diabetes trajectory rather than in the non-diabetic trajectory. So obviously there are various reasons. I will just delve deep because this is important why the society has changed in the last 20 to 30 years. So childhood obesity is actually the nidus from which, or the seed from which this banyan tree is actually arising. So this is a big problem which we are having. When you travel by aircraft, if you travel by Indigo, you will see it's written, दाने दाने पे लिखा होता है खाने वाला का नाम. So everywhere there is a food around you. So food is something which enthuses, entices and enthralls everyone, but there should be a limit. Like, what are the eating behavior types that we have? One is homeostatic eating. What is that? Remember those miners who were trapped in the tunnel for so many days and just kaju, kishmish and milk was just transported through that boring channel so that they could just live. So that is called homeostatic eating. Another eating is hedonic eating. Obviously, trying to eat chocolate suddenly when you are feeling depressed. So that is a hedonic eating. You just want to reward yourself with some food to tide over some circumstances of bad times in your life. And thirdly, obviously, is intentional eating. So many people would be just gravitating towards this, which HDS has arranged maybe in this counter just few minutes later, where I will be deviating from that counter. So maybe this is intentional eating. So these things have to be kept in mind. What are the problems of today's life, especially the kids that we are facing? The thing that I learned when I went to IIM Ahmedabad for a 2-day session on management, they said that when you go to a market with your kid, you will see that all the things that the child should not be eating are placed at the eye level of the particular child. That means colas, candies, chocolates and all those things, and the child would nag with the mother or the father that please buy me this. The problem starts from there. So this is actually the problem. So the eye line is the new byline. So we have to take some steps from the very beginning. Otherwise you do not blame later that type 2 diabetes is preponed happening at 20 years of age. Maybe the nidus or the seed is much earlier and we are not keeping a check on that. Now coming to the next part. So childhood obesity is one part. Another is thin fat Indian types. We all know this. I will just rush through this, that two people, one of Caucasian origin, one of Indian origin, having the same BMI will have different fat contents. Obviously, we will be harboring more. So just because I am lean and thin doesn't mean my visceral fat will not be low. So that thing has to be kept in mind. So this is the problem with thin fat Indians, that we harbor more fat. Another issue is that if we subdivide that, subcutaneous fat versus visceral fat. Subcutaneous fat is relatively a lesser evil because it is metabolically more active. But visceral fat is very stubborn to go. Once fatty liver grade 2 has happened, how many could you actually reverse? We can't do it. It's very difficult unless you have a drastic weight loss. So another issue I would say in Asia, food is actually a reward. Be it my son's birthday, be it your daughter has done well in the swimming competition, be it some other programs. Everybody goes to a restaurant nowadays. Only when somebody's family member does not die, everyone move to the restaurant to have some meal. This is the problem. And also after somebody has done and Shraddha Anushthan has been done, everybody will say, I have eaten veg for 11 days, now I need to go to a restaurant. So that's the problem where we are starting with. That has to be remembered. Anyway, so we collect a lot of visceral fat. So though we are thin, we are collecting more visceral fat. And those children who are having childhood obesity, obviously they will have more chance of type 2 diabetes. These are two actually extremes what I have said. Now from DCCT and other trials, what we have understood, legacy effect is very important. So no point in saying that. Only point is, you do something bad today, karma is a bitch, it will come back to you later. That we all believe. But what you do wrong today as a doctor, maybe your patient will reap the problems in later in life. So it is basically diabetologist karma that is going to haunt the patient. So start early with a molecule that can actually give a lot of benefits, not only looking at sugar control. We must remember that thinking of fancy products, be it GLP-1, SGLT2 and others, do not forget that sugar control is also important. So I have summed it up like this. This is just like the tree that I already posted, that from common soil hypothesis we generate CVD, obesity, type 2 diabetes, etc. So we need to actually address the stem, not the branches individually. And the proof of the pudding lies in the eating. Obviously we know this 2017 guideline was a watershed moment in type 2 diabetes management. Why? Because after lifestyle modification and metformin, you could have chosen any of the 6 classes of drugs without any bias and prejudice. But see what happened in 2018. Everything changed. Those molecules which were in the focus spotlight have been relegated to a corner, and some other molecules have taken the center stage. Why? Because now you need to scratch your head that it is diabetes plus something that will decide your therapy. So be it ACVD, be it heart failure, be it CKD, be it weight gain, be it hypoglycemia. So these points have to be in your mind to understand what prescription you are going to write for your patient. So sugar reduction is just the central point, and the peripheries also have to be managed. So don't forget that obviously those fancy products will have a cherry on the cake effect, but sugar management should also be kept in mind. So you should use all that you have at your disposal at your therapeutic armamentarium so that sugar control is achieved, as well as the target organ damages that might be happening, the seeds are actually coming up to become trees. Please address them from the very beginning. Now coming to the main part of the presentation. This was the preamble which I built up to drive home my point. So type 2 diabetes should be managed with a holistic and multifactorial approach. As I started saying, that GLP science is a fantastic one. Why? Because when you intake food, there is rise in blood glucose, there is native GLP-1 secretion. But the problem is, it remains only for a few minutes or seconds. It is broken down immediately after its job is done. So what we do actually is either you give some products from outside which remains at the site of action for a long period of time, which are GLP-1 receptor agonists, for example, semaglutide, or you use indirectly a DPP-4 inhibitor where you prolong the action of the endogenous GLP-1. I'll skip this. So therapeutic inertia is very important to understand that there is a tendency that when the patient is failing on 1 drug, 2 drug, 3 drug, we just go on adding drugs, but we need to understand post 3 drug addition, the effects are not good with oral agents. So at that time, maybe you need to add some basal insulin or something. So this presentation does not mean, to what I'm saying today, that where insulin is required, please substitute by semaglutide. What I'm saying is that where you require insulin, you will give it. Even it can be used with insulin, that I will show in the subsequent slides. So this is the trajectory of the patient that happens, that ultimately the patient lands up in insulin, and that also very reluctantly, very grudgingly. Neither the patient wants nor the family members want. Now, coming to the GLP family, what we understand that short-acting and long-acting ones are there. Out of these 3 molecules, I remember by a mnemonic, L, S, and D. That means lira, sema, and dulaglutide. They have been shown to have cardiovascular benefits. So semaglutide again available in 2 types. One is injectable, which is not available in India. Another is oral semaglutide, on which we are going to talk. Now, if we talk of the exposure-response relationship, it is almost similar for the oral and subcutaneous one. So be it be injected weekly, or be it be given orally once in the morning with not more than 120 ml water with no food or drinks, and in the next 30 minutes, the exposure-response relationship is almost similar. Now, it decreases the insulin dose as well. So in certain patients, you will see that if you are introducing this molecule, maybe the patient is having very lowish values of sugar. In those circumstances, you may need to reduce the insulin, and even if you are putting sulfonylurea on board, you might need to reduce it. Now, things changed in ESC guidelines 2019. You must be recognizing that pre-2019, metformin was the unchallenged poster boy of type 2 diabetes treatment initiation. But after this guideline was published, you could actually bypass metformin and give either GLP-1 receptor agonist or SGLT2 inhibitor as first-line therapy, as evident from this. And here you can note it is written there that in the lower part, SGLT2 or GLP-1 with proven CVD benefit. So for GLP-1, it is L, S, and D, that is lira, sema, and dulaglutide. So potential challenges with GLP-1 are many. So treatment initiation with an injectable is difficult because most of the GLP-1s that were available or are available are injectables. Treatment adherence is a problem because of potential side effects if you do not choose your patients properly, and optimal control also is very important. So what do patients prefer? Obviously, they will want to move away from vial syringe to once daily pen injections. Then you give them offer of once weekly pen injections, they would be happy. And then one day you say, okay, I will give you oral product GLP-1 which is available. Obviously, they will prefer that instead of an injectable. Now, coming to HbA1c and body weight lowering with oral versus injectable semaglutide in people with type 2 diabetes. This slide is very important, that you see with the color coding is evident that the orange color is injectable sema, which is not available here, versus the oral sema in the navy blue or deep blue color. They are almost comparable. So both weight reduction as well as good sugar control can be achieved with this set of molecules. Coming to the various studies that ultimately brought this market from bench to bedside, obviously the pioneer set of studies. Sustained studies were there for the injectable ones. What I need to say here is that the pioneer studies were designed very correctly, that in the pioneer 1 they started with monotherapy, pioneer 2 they compared with EMPA, in 3 they compared with CETA, in 4 they compared with LIRA. So injectable LIRA versus oral SEMA, that were checked here. And in 5, renal impairment was checked. In 6, they looked at a CVOT. I'll come to that in a little while. And in 7, flexible dosing as we use today in 3, 7 and 14 mg was used. In 8, insulin add-on therapy was used. In 9, monotherapy in Japan was seen. And in 10, OADs were there. Even after that, some studies were designed. I will just show in the last slide what are the future directions. So this is one review article written that gauging the anti-obesity potential of oral SEMA in type 2 diabetes in Indian context. Here there is a comparison. So on one hand you see oral SEMA placebo, then you see injectable SEMA placebo, and then you see oral SEMA 14, liraglutide 1.10 placebo. So these are the trials put together where you can see salutary response as far as reduction in weight and HbA1c are concerned. Similar is here. The gray one actually shows that more than 10% reduction, whereas the blue one shows the more than 5%, that is 5 to 10% body weight reduction. So in all you see a graded response. Now this was replicated in various observational studies also. In Croatia this was checked and they showed that it's an effective injectable semaglutide. As far as concerned, the comparison is quite good as far as glycemic and weight reduction is there. Now, Pioneer 4 actually compared oral SEMA versus subcutaneous LIRA. This I am focusing because this is comparing one molecule with its same congener or cousin brother in the other one. So, injectable LIRA versus oral SEMA was compared. And if you say as a summary, it checks the right boxes that you need. Maybe glycemic control, maybe effect on body weight, CV risk factor reduction, and pleiotropic benefits. And obviously reduction of hypoglycemia, because per se this class of molecule does not cause hypoglycemia. IGNITE was one of the first studies of real world evidence, and the results were again similar what we were seeing in the clinical trial mode. One of the earliest real-world evidence was seen, and the results were close to the pioneer studies. And the quest for first ever oral peptides was actually provided by Novo when they discovered this molecule and brought to us. Though we must recognize that this molecule has very low oral availability. So whatever you are giving, only 0.1% or something is getting absorbed. And that also you need a carrier molecule so that the local pH can be increased a little bit for a little bit of more absorption. So SNAC is actually that molecule that we do. So skipping these things, we will go into the next part, that early initiation of oral SEMA, achievement of clinically relevant targets is achieved, near normal HbA1c, effective weight loss, and fewer complications. And more number of patients achieve weight loss more than 5% with oral semaglutide, that also when you are using the higher dose. So maybe you are getting more benefits for patients who are actually continuing at 14 mg rather than at 3 and 7 mg. And there are various mechanisms how it reduces weight. So these are proposed mechanisms. They actually act at higher centers as well to suppress the appetite. Also they delay the gastric emptying. So there are a lot of putative mechanisms of action. There is another question, like some people ask that whether they actually cause lean mass loss. So there are some studies that say that no, lean mass loss is not lost. Actually fat loss is the mechanism by which the weight loss is happening. And also I must say that NAFLD, a lot of good studies are there to show that visceral fat can be lost with semaglutide. So beyond glycemic control, you are achieving many of the things. And also additionally, 1-digit reduction in systolic blood pressure happens. Maybe you will say this is not much to happen, but those patients who are put on 3 or 4 medicines from a cardiologist for BP reduction, this may have some good role as such. Also, it improves lipids. This may not translate very much into detectable changes, but at least they do not worsen the lipid profile. Vascular inflammation, it is seen that CRP also comes down. And it consistently reduced the risk of MACE. And if you look at the studies, the promising CV safety with 49% reduction of all-cause mortality and 51% reduction of CV death reduction for non-inferiority. This part has to be remembered that the pioneer study that was designed to look at the CVOT was not adequately powered to look whether the molecule is superior. It can only say whether they are non-inferior, that is, they are equal or not. So that was what achieved, and then subsequent studies were designed. So I'll skip this slide. So ultimately we come to the end of the presentation where we say, how do we look forward to the newer horizons? I think this is a different alarm. Anyways, so newer horizons are Pioneer Plus, Pioneer Real, Pioneer Teen, Soul Study and Evoke Plus. So there are some studies going on. Pioneer Real India, this has already been done in Switzerland and Canada, where real world evidence was collected about semaglutide, and these results will be published soon. We will be able to know what are the good things there. And oral sema achieved its primary endpoint for non-inferiority, as I said, in Pioneer 6, but this was not actually powered to see the superiority. That was why they designed this trial, and the collection of data has also been done. With time, maybe in some subsequent months, we will be able to know the top line results and the details of this. The important part is that about 800 patients from India were included in this study, and proportion of heart failure patients at baseline were about 23 vis-a-vis only 10 to 14% in the earlier trials, and sizable proportion participants treated with SGLT2 inhibitors, because it's a new study, so we are having more SGLT2 use in those class of patients which were not seen in studies pre-2015 or 16. We also have some encouraging things coming up, that in Alzheimer's disease, maybe this molecule may have some good results, and phase 3 studies are going on. Maybe we'll come to that. We come to the last part of the presentation. I would say when I was a kid, I learned this as Statue of Liberty, but today's kid learns this as Statue of Too Much Liberty. So this is the problem, that we have too much exposure to food as well. Of course, I must put a disclaimer, this is AI generated, otherwise I may be sued by Copyright Act. Anyways, so Pioneer trial, teens trial actually is looking at these people. So maybe below 18 in that adolescent group of 15, 16, 17, 18, whether this molecule can be used, because we do not have regulatory approval below this age. So maybe Pioneer teen trial will tell us something about this molecule. And lastly, just we took our Hippocratic oath that we should not do any harm to a patient. So before using any molecule, we need to understand and summarize and memorize where we should not use these molecules. So obviously type 1 diabetes, medullary thyroid carcinoma, and obviously the men syndromes, pregnancy, lactation, and relatively I put pancreatitis, though it is more a warning than a contraindication. And then cholecystitis, gallbladder stone also you need to keep in mind. So take home messages will be this, that many newly diagnosed diabetics are overweight and obese. Many of them are diagnosed very young, so have a long trajectory of diabetes. Early monotherapy or early metformin combination can be a plausible option when you are using oral semaglutide. Regulatory approval from DCGI has already been obtained as a first-line use. Lean diabetics may harbor visceral fat. Oral semaglutide may be of benefit. Weight loss, systolic blood pressure reduction, favorable lipid reduction are extra perks that you can have. CV safety, till now non-inferiority is established. Maybe we'll look for superiority. Side effect needs to be monitored, and future looks bright with many trials in the pipeline. So maybe the semaglutide story has just begun. And this is the last slide, that diabetes treatment is like treating or playing a chessboard. How you utilize your resources will ultimately determine whether you win or lose. Thank you.
Thank you. Thank you. Any question, suggestion, anything from the floor? Any question?
Hello, good afternoon. So, new article being shown that oral semaglutide causes optic ischemic neuropathy.
Yeah.
So, what about that?
Yeah, so when you are dealing with a new molecule, just as bringing up a new kid in the house, you will just know what are the tempers and tantrums of that child is going to create. So one of them is obviously NAION, as we have mentioned. It was published just few months back in JAMA, Ophthalmology, and the article is very interesting. What they said and what they put in the disclaimer, that actually is a matter of debate. And I think I have been given this topic in RSDD national program also, to talk about NAION. The issue is what they said, that out of about 300 odd patients that they examined, which were properly adjudicated by ophthalmologists, that they looked at the symptoms as well as optic nerve head edema, about 17 patients in the test group and about 6 patients in the control group actually developed NaION. And in the discussion they mentioned that we could not show causality, that means whether this is the cause, but we have to be careful and we need more trials which are adequately powered to understand whether there is a causal relationship between NaION and semaglutide. Also they mentioned that there may be other reasons of NaION in those patients, that means what are the confounders. So maybe type 2 diabetes itself, use of alcohol, other drugs, like you use pyrazinamide, you can land up in hepatic failure. You use rifampicin, you can induce enzymes. Similarly, either this is a change, something like this, or it is a causal relationship with NaION and semaglutide. That question is still unanswered, but it's a very good point that you raised.
Hridish, excellent presentation. So the word Hridish means from the heart.
Thank you.
So this question is from the heart. What do you feel is position in severe microvascular complication? Will this be the future?
Microvascular complications mean 3 things. One is in your department, obviously nephrology, so I will come to that. Another is, obviously I will put, is retinopathy. There are some studies with semaglutide which said that if there is a severe NPDR, risk of, this is one of the microvascular complications, if there is a chance of pre-retinal hemorrhage and all those things, maybe you should be a little bit cautious, because we are still having lack of data whether in those patients it can actually precipitate some pre-retinal hemorrhage and all those things. So better we screen them well. Those who are at the verge of just cotton wool spots are there, that's okay, acceptable. But some patients who are having some microaneurysms that are ready to burst, maybe in those patients it is better to avoid these. So patient selection is very important. First thing is not to tick the boxes, but to cross the boxes. As I said at the end, that these should not be the areas where you use. And secondly, should be the precautionary area. Gallbladder stone, gastroparesis. Because diabetic gastroparesis, gastroenterologists always say that will you use semaglutide orally when my patient is giving levosulpiride or etopride when I am having this gastropathy. Maybe those are patients where we should not be using. So that selection is very important.
Sema can cause gallbladder disease and pancreatitis. But is it safe in hepatic dysfunction? How will you adjust the doses, or you will give as such?
No adjustment of doses has been advocated, and I have a little exception to the term that SEMA can cause. SEMA is associated with that, so there are some issues that pancreatitis may be precipitated in susceptible individuals, not in all. Because we use, if we say that it causes, then all patients which you use actually will end up. So that doesn't happen. But of course, somebody who said, Mera pancreatitis hua tha, maybe I will be the last person to think of this molecule. So that is actually the doctor's discretion.
Thank you.
So whatever data we have, as I showed, till now we have non-inferiority data. Superiority data we do not have. But there is no contraindication to say that in severe heart failure means how much? Did you classify? Yes, I will use that. Till now, I do not have any data to contradict, but as an endocrinologist, I will still seek the opinion of a cardiologist here.
I think that will be helpful. Anyway, thank you for your...
What? Oh, okay. So whatever you use, like in Narayana Hospital, we all have doctors here. Whenever there is an organ coming from another city, there is a green channel created by the Kolkata police to reach the NH. Similarly, this molecule should give in a green channel for at least 30 to 40 minutes before giving anything. So be it fruit, vegetables, levothyroxine, ibandronate, gas medicines, glimepiride, anything. So 30 minutes to 40 minutes green channel has to be provided. After that, you can give anything.
Thank you.
Thank
Let
you
us close
so
the
much.
session.
Thank you, Speaker. Thank you, Chairperson. I would like to request Dr. Sanjay Shah to please felicitate our Speaker and Chairperson. Thank you so much.